This is Resuscitation, Lecture Number 1, ACLS, The Basics. When people think about a code situation, I think they typically think of something like a Rube Goldberg machine, something that's very complicated with lots of moving parts. But the fact is, ACLS is quite simple. At the end of the day, there are really only 5 things you need to remember to make ACLS work. Before we get started on those, remember, these patients are dead. They can't get more dead. This can only get better. So the first thing is, calm yourself. Now moving on. Step number 1, evaluate your patient. Check a pulse, and if they're on a cardiac monitor, look at the monitor. ACLS is indicated for the unconscious patient without a pulse. I have seen CPR started on someone who is sleeping. I have heard stories of residents shocking patients who had a Parkinsonian tremor or had a seizure. Don't be that guy or girl. Evaluate your patient. When you've established that they are both unconscious and pulseless, then move on. Step 2 is effective chest compressions. In a real-life situation, you're not thinking in terms of centimeters or inches, so just push hard and push at about 100 beats per minute, or the beat of staying alive. Now remember, you are supposed to be leading this, so as soon as you can, delegate. Have someone else start chest compressions and allow you to step back and start thinking about the situation. While we're delegating, if the patient doesn't have an IV and is not connected to the cardiac monitor and pads, now's the time to do it. Step 2 is airway. Now, airway is something that historically has been a bit overblown in ACLS. All this means is somebody needs to be delivering oxygen to this patient, usually by a bag valve mask. This is not the time to get complicated. No studies have ever shown an improvement in outcome by intubating these patients. Keep it simple. Stick with a bag valve mask, and as soon as you can, delegate this job to someone else, a resident, a medical student, a respiratory therapist. Then step back and start thinking about the patient. Now that we have people giving good, effective chest compressions, and we have somebody delivering oxygen by a bag valve mask, we can now delegate somebody to give epinephrine, 1 milligram every 3 to 5 minutes. Now, admittedly, the evidence behind epinephrine in ACLS is weak, but it does provide a timetable for us. It reminds us when we need to do pulse checks and when we need to deliver shocks. Which brings us to our last step, defibrillation. Defibrillation is the most simple part of this whole algorithm. If the cardiac monitor looks like a scribble, then you defibrillate the patient. If it looks like a normal sinus rhythm or a flat line, you don't. And that's it. If you do these things, you may not be a rock star of resuscitation, but you will be able to do an adequate job of resuscitating the dead. Now clearly there is more to ACLS than just this. Many of you have heard of H's and T's that's associated with asystolic or PEA arrest. That's a little more complicated than we're going to go into now, but we will revisit it in a later episode. Furthermore, there's some debate regarding when it's okay to call the code or quit. But that's more than we need to go into right now. So, thanks for listening, I hope this has helped, and stay tuned for further episodes where we dive into this subject a little deeper.